Hello, and welcome to the latest installment of our In Conversation podcast mini-series, where each episode delves into key themes and topics raised by Intellect's recent book publication, Fighting for the Soul of General Practice, The Algorithm Will See You Now. My name is James Campbell, and as always, I'm joined by Doctors Rupal, Shah and Jess Foell. Our focus today is on the benefits and threats posed by the so-called AI revolution in healthcare. To explore this critical topic, we're also delighted to welcome two esteemed experts, Dr. Jess Morley and Dr. Richard Lehman. Hello and welcome to you both. It's great to have you on the podcast, and also hello to you, Jens and Ru. Wonderful to have you as always. Perhaps to begin with, though, I'll go to Jess. Can you just give us a brief overview of who you are, kind of what your role is, what your research is, and how it relates to general practice?
Yeah, sure. Thanks so much for having me. So my name is Jess. I guess I should first caveat this given the context of this conversation and with the other people on the call, in that I'm the least useful doctor of everyone on this call. I am a doctor of philosophy, not a doctor of medicine. So if anyone has a medical emergency, don't ask me. But other than that, I am currently a postdoctoral researcher at the Digital Ethics Centre in Yale University. I've been here for a year. I do research on essentially how do you make digital technologies work in healthcare in a way that is ethically justifiable, socially acceptable, as well as technically feasible and legally compliant. And before I was in Yale, I was in Oxford for many years. And before I was in academia, I actually used to do primary care commissioning. That was my very first job for many years. So that's why primary care is so close to my heart.
Thanks very much, Jess. I appreciate the introduction. And Richard, over to you.
Yeah, you've described me as an expert, but I'm really a lifelong non-expert. I'm a journalist, and I've got into this field because through commenting on medical journals and being a GP throughout my working life, I got to be professor of the Shared Understanding of Medicine in Birmingham for 3 years, which was an imposter role. I realized, that nobody can really share the understanding of medicine in a 3-year post. And it occurred to me that really we were trying to make the human mind do things that were impossible and that were yet necessary, because ill people need to understand their treatments. Doctors need to understand their ill people. And bringing those two minds together at points of crisis is a totally different role from anything else in human life. And so I retired, and in fact, my wife died at the same time, and I was in some despair about where it had all gone. And then suddenly I was having conversations about generative AI, and perhaps wrongly, I thought, this is the light bulb moment. This is where medicine's going to change. All the things that previously I thought impossible now are possible, but can they be shaped? Can they be made to be humane, to do the tasks that we at the moment do with human fallibility to the best of our ability, but perhaps not always very well?
Thank you, Richard. I really appreciate that. Well, let me start by kind of asking you a pretty straightforward question then, but one that I'm sure our listeners will be really interested to hear about. I think we've heard quite a lot about this AI revolution in healthcare, but are we currently entering an AI revolution? Are we in an AI revolution? And what does this kind of look like? And how might that sort of start to reshape the future of healthcare? So first of all, Richard, are we in an AI revolution within healthcare?
I mean, we are. Yes, I think this is the most exciting moment in the history of medicine, actually, because the abilities of AI to understand disease mechanisms, to communicate, to translate, to operationalize all sorts of things which are very difficult to operationalize otherwise. That has to be an amazing threshold to cross, and it's being crossed bit by bit in various improvisatory ways, and I think that's the way it will continue, in fact, and that everything we speculate about in this podcast is probably going to be proved wrong or incomplete, but nonetheless, it is an amazing step. And it's quite different from the AI discussions that have gone on since really the late 1930s, when Turing first came up with some of his theorems. the stuff that's coming out now is basically beyond our understanding, although we construct it, and it may be beyond our control. And that is another issue that we're going to talk about, no doubt, later on.
Thank you very much for that. Jess, how about you? Does that line up with your own thoughts on this?
So I am, and this is not something I'm saying that they don't already know. So I am probably a bit more skeptical than Richard as to whether or not this revolution is really happening in the real world. So I think we are undeniably in the middle of AI-driven healthcare research revolution. I wouldn't yet say we are in the middle of a medical revolution. And the reason I say that is because much of what we're seeing happen in science and big university buildings like the one that I'm currently sitting in is not necessarily actually making an impact on patient care. And that gulf is actually widening rather than shrinking. And I think it matters because for several reasons. One is that at some point, unless we grapple with that reality of there being a bit of a gulf between the sort of research and the clinic, we will start to see people become disillusioned, and I think we'll see things fall out the bottom, which is what we have seen happen with AI in the past, where you've had these big peaks of interest and then these massive crashes, which is what some people often refer to as sort of AI winters and summers. The other thing that I think matters, and hopefully we can get into in this conversation, is that I think by seeing AI as the solution to everything, we're missing the opportunities where we actually can make a real difference with AI. And what we should be really focusing on is what are the very specific things that only AI can do and that we know it can do very well, and then how do we get those things right is how we will truly see an AI revolution, because there are things, as Richard has said, that only AI can do that were previously impossible. But there are also things that AI is not very good at and it isn't well suited to. And being able to differentiate between those two things is really important, particularly in the case of healthcare, where we're dealing with people and people's lives.
Oh, thank you very much, Jess. I'm definitely gonna come back to you so we can explore some of these particular uses and some of the pros and cons for AI for sure. But Jens, you're on the front line. Let me bring you in here. Does that line up with your experience of AI within your clinic?
It's there as a topic or a hope that AI might, on one hand, do drudgery work, write complaint letters, replies to complaint letters, fill out forms, housing forms, and so forth, hoping that there are efficiency savings, so to speak, which is juxtaposed against AI is so much better in diagnosing, where I think as a GP, how often do I diagnose? That's not a problem. So like Jess, I see there's a big disconnect between where it could be really useful and helpful and where bigger promises are. What I see in my immediate context that more people are using ambient AI to help with documentation. Other people have reservations about whether this material is used for training purposes, and hence confidentiality issues are there. And there's at the same time a big fear and hope, like a bonanza experience where you have pushers, hopefuls, skeptics, etc. It's very interesting.
And Ru, can I ask you for your take before we go back to Jess?
Yeah, I haven't used AI personally in my practice, and I've had mixed reports from other colleagues who've used software like Heidi, which transcribes consultations. So I think there's inadvertent effects that we might not think about. So people who haven't been so keen, for example, on the transcription software, have said things like it makes you miss that reflective time of writing up notes where you're kind of trying to make sense of what happened, or it's recorded without any nuance, so the kind of subtleties of the interaction are missed, and also it may affect things if they feel that everything is being recorded. So I think it could affect what is said. So I think there are consequences which might not be obvious, but we shouldn't lose sight of the fact that healthcare is very complex and unpredictable So these technologies have to be used and implemented with care, I think.
Thank you. Jess, let me come back to you. And you obviously mentioned there that there are some specific cases and opportunities. So I thought this might be a good way for us to look at some of the benefits and potential applications for AI as you best see them within healthcare. Would you like to maybe kind of go through a few of your kind of like some of the top opportunities as you see them?
Sure. So I think there are three, and I'll touch on the first two quickly and then the last one for longer, because I think the first two other people will probably also say. So the first one is, I do think that there is a big opportunity in terms of lessening the administrative burden on healthcare providers. I don't think that that necessarily means that their healthcare providers are going to suddenly have maximum more time with their patients, but I mean, as the whole healthcare system is really burdened with admin, not just in terms of things like writing discharge notes and all of that type of stuff, but also in terms of performance management and contracts and knowing where staff are and knowing what stock we have. Like there was a piece of analysis that was done a while ago, which was absolutely beautiful, and it was basically how much nursing time is wasted by nurses not knowing where the bedpans are. And it adds up to like a week. So these are the types of things that I think AI could actually do spectacularly brilliantly and release some of the admin burden. That's number one. Number two is, I think it will help us with people who have long-term conditions. So I don't necessarily buy into this idea that AI is going to become this all singing, all dancing prediction and preventative machine, but I do think what it can do really well is act as like a companion for people who have long-term conditions and have to currently get passed from pillar to post, and this part of their body is dealt with by this clinician over here, and that part of their body is dealt with that person over there, and then things fall through the gaps, and people get very frustrated about who's got my notes and why do I have to keep repeating myself. This is the perfect way for AI to act as like a companion person who can walk you through that journey alongside you, make it easier to interact with your own record, for example. So that's sort of number two. And the third one is actually where I think we could potentially see huge benefits from AI, which we're currently missing, is from a science perspective and from public health. So I think we have somehow down the road forgotten that the way in which we made biggest gains in human healthcare over many decades was by really focusing on population health. All of the interventions came at that sort of level, and that's where we've seen the greatest gains in healthcare. Everything else is sort of made like small tweaks, but things that have made a really big difference, focusing on sanitation, focusing on smoking cessation at population level health, antibiotics, vaccinations, these things. We know from just a health science perspective that medicine, unlike clinical care, makes relatively small proportion of difference to the extent to which people actually have healthy lives. The vast majority of that is coming from their social determinants and the overarching environment within which people live, which to Ru's point has actually traditionally been almost too complicated for us to get our heads around. Like the factors are so many and there are so many different things involved, and we don't know how to intervene, and we don't know how to figure out where do we go upstream or downstream. Those types of opening up the questions and pattern recognition are the amazing things that AI can do that humans are just incapable of doing because we do not have the cognitive capacity. So I would really love to see AI in healthcare being used more for science and understanding of the population health types interventions, as much as we are seeing them being currently focused on very narrow uses in actual clinical medicine. And I think that's where we'll start to see some really significant gains to overarching health of the population.
Thank you, Jess. That's a fascinating insight, and I want to bring in my colleagues here today to respond to that as well. Richard, can I start with you? How does Jess's perspective and her sort of some of those ideas around benefits, how do they line up with your own? And do you have any comment on that third point that she raised there?
Yeah, I mean, I think I entirely agree with everything that Jessica said. I mean, it's very easy for me, from my perspective as an old man, philosophizing and hoping that humane medicine will suddenly regenerate through technical means, to sound very airy and unpractical. And I think certainly these administrative advantages are enormous and need to be deployed. And that is something that can be controlled by a National Health Service, for instance, and should be. The trouble is the National Health Service is very, very slow in its technical adoption. And so a lot of this is already patchily happening through commercial systems being deployed in general practice. And I'm talking really from the point of view of a GP. As far as the final point that Jess made about let's do the middle point, because the health companion for those with chronic diseases is a concept that I think we both fervently agree on. People with long-term conditions, particularly in the United States and in the more developed and more exploitative health systems, have absolutely no hope of getting all their care coordinated properly. And I would imagine that in poorer countries, in some ways it's even worse, because there's very little provision for them to turn to. So they turn to other sources such as religious systems and family networks and so on to get any kind of care at all. And these problems exist across the world. And I think we should take a global perspective on the advantage of this and not concentrate too much on being touchy-feely doctors in the West, but people who are actually doing stuff that Florence Nightingale was trying to do in India in the 1880s, just get basic sanitation. And now we're coming on to the third point, which is that public health, yes, could be massively coordinated if the political will exists. At the moment, it's being dismantled actively by right-wing governments in various places, which I hardly need name. Anyway, so we're enthusiastically in line on that. I think it will make medicine safer altogether, because incompetent doctors will have nowhere to hide. Not that they should hide, not that they should be expelled, but they should be taught how to improve. And I believe that generative AI, by observing doctors in confidential situations, could actually make the generality of practice safer. But the biggest thing that will make the generality of medical practice safer is patients actually taking this into their own hands. So I don't see this as a top-down system thing at all. Patients are going to use and already use generative AI more creatively and more widely than doctors. And they're going to demand that doctors actually consider diagnoses. We may fear that. We may think we're going to be overwhelmed by fanciful propositions and dead ends. But I'm sure that AI can be designed to avoid that. It'll make medicine more rational. It'll stop the false labeling and the commercially driven tendencies to diagnose everything before it's actually happened. It should do that. In fact, it's doing the opposite in some centres, where they're actually trying to sort of make everybody into disease waiting to happen and be intervened with by some wonder drug and some tests and some follow-up and some other burdens on the system, which are entirely intolerable. And finally, I think medicine's going to become far more equal, because patients will have equal access to everything that doctors have, basically. They'll expect compassionate narratives, because AI can already provide compassionate narratives that patients prefer, in fact, in many circumstances, to the sort of fields that we as doctors fumble at in moments of difficulty. So all those are positive points. We're going to come to the negatives, no doubt.
We are.
I think I've downloaded myself now. Okay.
No, Richard, thank you very much. I really appreciate all of that insight. And again, it's really interesting to hear your take on this. I do want to give Ru and then Jens an opportunity to respond, though, because I know that I think they'll have some interesting points to say around things that you've both raised. So Ru, let me go to you first. Would you like to reflect on these comments?
Yeah, it's kind of a question for Jess and Richard, I guess. In other podcasts, we've talked about failure demand. So the demand created by failing to do something right for patients, who might be in front of you. And one of the causes of failure demand that we've talked about on the previous podcast is misidentification of need. I'm kind of wondering about, say, something like diabetes, where there's I mean, I think literally billions of pounds spent per year on diabetes management from a very medical point of view, which seems to me to be kind of relatively lacking effectiveness, but we still do it. And I wonder whether there's a role for AI to do some calculations and say, actually, you'd be much better off spending this, these billions of pounds in a different way.
Yes, that's sort of what I mean in terms of both the population's health science and the reducing of an administrative burden from a management of the systems thing. I think when we think about AI, what we have to remember, the best thing that it is able to do is take in a lot of information and see patterns in that information that we are not capable of seeing. And yes, that can be kind of helpful for diagnosis, but actually a lot of the time doctors are pretty good at diagnosing people already. Where we see the limitations of that type of stuff is exactly what you were describing. Is this really working? Could we do it better? Are we genuinely serving the population, whether that be a big one or a small one, in the most helpful way?
This is exactly where I'm coming in. I compare AI to systematic reviews and nice guideline production, which exactly takes a database, a training model, but you have lots of people who do that for years and years and years. It takes 4 years to come out at a guideline, and at that time it's probably outdated and unclear whether it's relevant to the population you're serving. So if I have a hope where calculation models could have an up-to-date, specific idea of what helps for whom, under what circumstances, that would make me very happy. And at the moment, we have very static, rigid guidelines which position a truth, which is all a construct. And I'd like to know what I don't know. I'd like to know what's happening in my area, what's happening to this social strata I'm serving. And I think computer models could help in providing guidance, data, information that I can then interpret in decision making or in policy development. There's huge chance and possibility.
Yeah, we just do things. I think it feels heretic to question it. So, for example, as a practice, we spend a huge amount of effort trying to get everyone with diabetes in to have their 8 care processes done. And I really question the overall benefit and whether you'd be much better off doing things in a different way at a community level. The effectiveness of me explaining diabetes to a patient, again, I really question that, or some of the education programs. So if AI could help steer us away from these fixed ways of thinking, that would be fantastic.
Well, Jens, well, let me bring you in again there.
Yeah, a quick one. As a cynic, I can see then AI as helping being regulated. So with all our education work, appraisals and portfolios, they're increasingly done by AI, but they can also increasingly be analyzed by AI, and then computers will take away all the work of being regulated.
Well, I think that is the danger. I think, I when I was first thinking about this, I thought what we need is a health companion for patients, which is exactly what the language that Jessica used, and a guardian angel for doctors. Now, it's very important that this guardian angel has no God to report to. If it's going to work, it's going to simply report back to the doctor what they could have done better. I think the idea of a God who would become Elon Musk is terrifying, and that's one of the disadvantages I was going to point out later. But if it were done confidentially, so that the doctor simply had to show that that they had used a system of feedback to show up perhaps some weaknesses in their knowledge or in their communication or in their management or their diagnosis. This is not available to 99% of doctors in the world. We are thrown out there. We in Western societies, we game with these appraisals and fill out this and that. But for the vast majority of medical practitioners, there's no one actually looking over their shoulder, and that's why we get these periodic scandals. It doesn't have to be intrusive. It doesn't have to be big brotherish. It doesn't have to be run by Elon Musk. I think that that's one of the things I'd like to see happen, but of course it may not.
Let's focus on some of the potential risks and worst case scenarios, because as you highlighted earlier, Richard, there's like AI is not actually a new thing, but obviously the amount of coverage it's getting in the media and the new options that are available to the general consumer, things are rapidly changing. So although it hasn't just turned up overnight, I think a lot of people still have these kind of Terminator 2 childhood memories, kind of notions of AI out there. So let's talk a little bit about some of the potential risks and worst case scenarios, because it isn't all utopian, is it? So Jess, maybe I could bring you in on this. What are some of your sort of fears and concerns about the widespread application of AI across healthcare?
I guess my most biggest fear is that we will not design the system correctly, and therefore we will cause harm and miss the opportunity. That's the biggest thing, is that by doing rushed implementation rather than slow thinking of where we can get this right, will cause significant harm that will result in a chilling effect. People will fall out of love with the concept, and then we'll miss the opportunities that we could genuinely do things well. So that's kind of my macro level fear. My other two concerns are, one, that we'll forget about the art of medicine. So people, I think, get too bogged down sometimes in this idea that medicine is just about taking in, it's a numbers game, that it's just about taking in people's symptoms A, B, C, and then spitting out diagnosis D, and then adding in prescription E, as if it's just like this sort of equation that we can quantify and automate. And I don't think that's true. I don't think that's what patients want. That's not what delivers good healthcare. That's not what delivers good health outcomes. It's also about understanding people's own feelings and their lifestyle preferences and all of these types of other softer things that algorithms are just not capable of understanding, because they don't have that built into them. They are not intelligent in that way. So that's sort of my second big thing. And my third and final one, and then I know we want to speak, is that we create this system, sort of like I sometimes call a two-tiered system, between people who are, like me, rarely sick, but generate very, very good quality data on myself. And so I could be treated extremely well by AI, because it will largely tell me, oh, there's nothing wrong with you. Maybe you have a mild cold, or it will recognize well when I'm ill. But then there are all of the other people who do not generate good quality data on themselves, who are more likely to actually need the healthcare service, and we'll see this sort of divergence between the sort of worried well data rich and the ignored sick data poor, and that worries me enormously as well.
Thank you, Jess. Really, really interesting points. And yes, let's go to you, Rube, because I know you've been waiting for a minute. Please, what Jess
No,
say?
it was so good to hear Jess put it that way. I think everything I've been thinking comes under those categories. I worry that if we don't challenge the paradigm that we're in at the moment, which is kind of like a factory model, or this idea that you can regulate everything, that incentivizing things always works and will influence behavior from a healthcare point of view, then I think AI could just make everything worse. So we really need to rethink the nature of health and healthcare interactions, as complex adaptive system, if you want, and not in the kind of reductionist way or the factory model that we've got at the moment. And that is like, how do we do that? That really kind of concerns me. And also whether it ends up with, referring to Jess's second point, a sort of medicalization of life generally, where you kind of just see people as a collection of symptoms, either that they have or waiting to happen. So either pre-diseased or actual disease. And that is a terrible way to live one's life, I think.
People are already scared to say that they've ever been anywhere near a cigarette or an alcoholic drink. So yeah, I think there's going to be there's a general fear and about sharing data anyway, isn't there? Jens, can I bring you in here?
Yeah, likewise, looking back at the experiences of COVID and technological changes, I fear that it will enhance the inverse care law and produce more data and more care for the people who need it less by socioeconomic position, and others are simply ignored?
Yeah, well, those are fears that I do share, and I think they're real, and I think that's the direction it would go in if it were controlled by industry and by the medical profession. I'm hopeful that it will not be, that it will be controlled by patients who will suddenly realize that they have a lot more knowledge and a lot more power in these processes, and it will be adopted by the genuinely good politicians wherever they may happen to be. Search for one and find, it's like searching for the honest man with a light in Athens. That Archimedes, what was his name? No. Anyway, let you get my point. It's just that things are so unequal and so stupid at the moment in terms of labeling. Rue mentioned diabetes. Type 2 diabetes doesn't even exist. It's a factoid of and it's generated by our historical understanding of what sugar in urine means. And now we have to rethink all these medical categories. And I think generative AI is going to be quite good at that. And it's also going to be fairly authoritative, perhaps too authoritative. Perhaps we'll learn to depend too much on it. But it will see patterns within what we call type 2 diabetes that are best treated one way or the other. Because at the moment, type 2 diabetes is just really semaglutide deficiency disease. There's a good treatment for it. It's commercial. It's made Novo Nordisk so rich that the state of Denmark can't even compete. And this could be reproduced. I mean, this is very much the Trump-Musk model of how to exploit humanity. But what if humanity, who after all outnumber them by 7 or 8 billion, actually get these? They've all got mobile phones. There are more mobile devices now than there are flushing toilets in the world. And it only needs 1 or 2 of them in any given community to spread real information. And the one good thing about AI is that by combining material from all sorts of sources, fortunately, most of the sources are truthful, and therefore it's a good sifter out of what's real and what isn't real. So those are my hopes. My fears are just the same, that it's going to dehumanize medicine, that we're going to become de-skilled, that we may end up living lives of idle hedonism, which don't mean very much because everything's taken over by the great sort of God machine in the sky. But I'm more hopeful than that. Humans are creative. We'll find good things to do with each other. We might even develop a science of practical compassion that's actually made up of all the elements that we've been discussing. Now, that's a good thought, isn't it?
Yeah, that's an interesting thought, certainly. Would anyone like to respond to Richard's comments?
Yeah, a compassion enhancer would be fantastic. That helps people not getting fatigued by having too much cognitive overload and helps in connecting to people. Definitely, yes. And many people would like to share emotional reactions with somebody that is not biased or not explicitly biased. So as a touchy-feely person, I can have many hopes for AI to help me.
Thank you, Jens. Does anyone else have any other kind of major sort of fears or concerns they'd like to highlight? Because I know that a lot of people listening will be concerned about, biases and things like that, and missed diagnoses, but also maybe misdiagnoses, especially if the patient is working with AI. So any other major concerns or issues that any of you see?
All of that really falls within my category of the people who are data rich and not very sick, and the people who are data poor and who are sick. So when people talk about bias and things like misdiagnosis or inaccuracies, that sometimes gets oversimplified to this idea that when we're talking about bias, all we mean is whether or not we have a data set that has all ethnicities in it or all genders. It's definitely much more complicated than that from just a purely statistical perspective. Bias can come in all sorts of different ways, whether that be because it's like things like target specification bias, so i.e. we target the wrong outcome for the wrong type of patient. It might be that there is just information that is not recorded. There are whole swathes of the population who have really good historical reasons for not wanting to disclose certain types of information that is therefore not in their electronic health record, or they just don't go to the doctor, which is why they're not in the electronic health record. Or, we have huge numbers of women now, for example, in this country, not wanting to record anything to do with like their menstrual cycle because they're worried that that's going to get them in trouble with the anti-abortionist people. So all of these sort of social issues start trickling down and affect the data quality that we have that we train these models on. And there is therefore this sort of huge disconnect between what data we have, who it represents, how good that data is at representing the different types of people, and the type of utopian equality driving, improving vision that we sometimes have for AI. So whilst it's important to do things like think about bias in terms of the way that people talk about it in like a sense of, do we have representative data sets? It's also just about recognizing the fact that the data quality of who has good data quality versus who has poor data quality on them is really a phenomenally difficult thing to fix. Technology companies will want you to think that it's just about de-biasing data sets because that's a relatively simple tech fix to do. And they can tick something on an audit chart that said, yes, I did a de-biasing check on my data set. That is much more nuanced and complex than that, which is why I try to talk about it as a sort of macro level fear as opposed to a specific level fear, because otherwise I think we get into these tech fixes rather than talking about the sort of social dynamics of what's really going on.
Yeah, I agree with Jess's point. I think, though, there is a possible positive side in that that generative AI will gradually be recognized as a marvelous communication tool for people who are otherwise underrepresented and inarticulate. It only takes a language to be spoken by maybe 10 people in the world, and the AI can translate with nuance into any other language in the world. I am told, I've never tried it. Similarly, every educational level, including illiterate, could theoretically be given a voice that it would recognize as its own, in fact, spookily by AI. And so gradually the data sets would improve, perhaps. It's not going to happen overnight. I don't think perhaps we should be too fixated on the quality of data overall, but certainly in terms of empowerment, as Jess was saying, that underrepresentation of women, particularly in societies where women are basically owned by their men and never get to make any decisions about their health without a whole lot of family intrusion, particularly male family intrusion. I think those are circumstances which we can speculate may improve with AI, but maybe they won't. Maybe they're intractable for our lifetimes. Anyway, I like to think of it as this as a phase of improvisation. We're thinking in terms of what we can control. I think we should also think in terms of what we can't control but may go right, and in terms of what we can't control and may go wrong, all the time remembering that we cannot control it. It's a technology that is so democratic that nobody can fully do a dictator on it, for better or worse.
Thank you very much, Richard. Well, look, before we wrap up, I'd like to give everyone an opportunity to kind of make any of their final reflections. But perhaps Jens or Ru, I can go to you first. Do you have any thoughts on what our guests have just shared, or would you like to share any final reflections of your own?
Very grateful to Jess and Richard for fantastic insights. Thank you so much. I'm just interested to kind of think about what the role of the clinician will become and how that will change with AI. And I suspect we'll have to become better interpreters, better enactors of practical compassion, Otherwise, we will become defunct, but maybe that's okay.
I am fearful that it will be a social divider, and I'm hopeful that it helps me bridging population health with individual health, mindful that I'm more on the pastoral side of things than on the side of extending in lives. That's fine. So I'm very, very much in favor of Jessica's macro model and seeing and interpreting the data that nobody can interpret. That makes me passionate and really interested.
Thank you, Jens. And Jess, Richard, any final thoughts from either of you?
I think the issue is that life is a condition of inevitable uncertainty about most things. And there's a beautiful book just been written by David Spiegelhalter called The Art of Uncertainty. We all live in an uncertain environment, and to the extent that AI doesn't understand that and puts false certainty into every situation, it's going to be disastrous. But actually, people are already working on AI systems that learn humility and that learn that deep uncertainty exists. And we come across this all the time in medicine. The vast majority of our patients never want to see us and only come when they need to. Some of them grow to depend on us for psychological reasons. Others, greatly outnumbering them, do so because they're forced to through chronic illness. And we don't know what's going to happen at every point in their illnesses. And we know they're going to die eventually, as we are. So I think we need, it's going to deepen and rehumanize medicine if AI can really be used as a tool towards that. So I'll end on a cautiously optimistic note that the art of medicine, as Jess described it, will actually have to be enhanced. We'll have to become better artists.
A lovely sentiment. Jess, Morley.
So I think I'll end by saying that AI is not exceptional. And there are people out there who are going to scream when I say that, but it's a positive and a negative. So when I say it is not exceptional in a negative sense, what I mean is we should just remember that it is just a tool. It is one tool that we have available in our arsenal. It's a very powerful one that we can direct its use to different types of uses, but it is only one. And then there are two ways of which you interpret that. So from the sort of negative side is that means we do not treat it as if it gets a free ride. So we do not treat it in medicine as if it is not something that needs to be considered, that needs to be regulated, that needs to generate good evidence that it works, that needs to be co-designed with the people who are going to benefit from its use and who will actually use it. That's patients and clinicians. And that means that we also have to, think about things like procurement frameworks and insurance and contracts so that we don't hand over all of the power to the big tech companies because they think that they can just walk in and be like, oh, look, I have magic beans. No, you don't. You have one more medical technology that we know how to use. And then the other way of seeing it as it is not exceptional is it isn't magic. Like I just said, it's not a magic beans. It's not going to solve all of the problems that we currently have with contemporary healthcare, but it is going to solve a few. And the more we focus on the few things that it can do really, really, really well, like no one got mad at the fact that stethoscope can't do surgery. Like we don't need an operating stethoscope. We do not need AI to be able to do all of the tasks in medicine, but we just need it to do a few very, very well. And we need to focus on making sure that those things deliver the benefits that we know it can before we all sort of get carried away and then disillusioned. So that's my end note. AI is powerful, but not exceptional.
Well, that brings us to the end of today's discussion. So a huge thank you to Drs. Jess Morley and Richard Lehman for sharing their insights. It's been wonderful having you on. Thank you so much for your contributions. And of course, to my co-hosts, Drs. Rupal, Shah and Jens Foell. And if you've enjoyed this episode today, don't forget to subscribe and stay tuned for more conversations on the future of healthcare. Until next time, thanks for listening.